Um, data everywhere, not an insight to spare. Is this really true? Have we been able to adequately use technology to generate insights and actions? What role does technology play in improving primary healthcare? And what challenges do we face in implementing it effectively? Good evening, everyone. Welcome to the fourth episode of the dialogue series on primary healthcare, an initiative by the Center for Primary Healthcare at BHS and Center for Healthcare at IIM Udaipur. Basic Healthcare Services is a not for profit organization driven by the vision of enabling marginalized and vulnerable communities to lead a healthy life with dignity through a network of primary healthcare clinics. BHS provides healthcare to rural and tribal populations in the districts of Udaipur and Dungarpur in southern Rajasthan. The BHS Center for Primary Healthcare conducts research on critical primary healthcare issues such as human resources for health, health system strengthening, early childhood care, nutrition, and adolescent health. The Center for Healthcare at IIM Udaipur focuses on healthcare related research from a management perspective. It serves as a platform for researchers, practitioners, policymakers, and other stakeholders to collaborate and create evidence based impact. Currently, the center prioritizes research in primary healthcare, addressing a significant gap in research on this topic in India. The dialogue series on primary healthcare aims to highlight key issues in the field, bringing together researchers and practitioners to discuss evidence based insights. In today's episode, we will focus on technology in primary healthcare. India's primary healthcare system faces numerous challenges: limited accessibility, resource constraints, uneven distribution of health services, and so on. However, technology promises transformative solutions here, whether it is through AI enabled diagnostics, telemedicine, mobile health applications, or integrated digital health records. The key question, therefore, is how can we best leverage these innovations to make primary healthcare more efficient, inclusive, and patient centric? To explore these questions, we are honored to have two eminent panelists with us today. I invite Dr. Pavitra Mohan, co-founder and director of BHS, to introduce our speakers for the day. Pavitra, you are on mute.
Thank you, Veda, and good evening, everyone. It's absolutely my privilege to introduce the two speakers today, and they're very unusual in a sense that we often talk of the bridge or the divide between practice, research, and innovations. And here there are two uh, people who both are medical doctors, and they bridge this divide between research, practice, innovations, and technology. They are both practicing physicians as well as technologists who and therefore what they bring to the table is pretty unique. um, So the first speaker is Dr. Shrey Desai, who is a public health physician and serves as director research at Seva Rural Jhagadia in Gujarat, a not-for-profit organization that has been serving the rural and tribal populations of Gujarat for last several decades, and it has inspired many young health professionals of our generation. Shrey and his team developed, implemented, and evaluated TECO, a digital platform for healthcare that has been subsequently adopted by the states of Gujarat, Uttar Pradesh, and some other UTs. A huge, challenging task working with public systems on large scale, and we would listen to his experiences and insights and evidence from his work of implementing statewide health management information systems for primary healthcare. Our second speaker is Dr. Anthony Vipin Das, who is a consultant ophthalmologist and a digital health specialist. He developed iSmart electronic medical records that have clocked more than 15 million patient visits at the what is known as the pyramid of healthcare systems at LV Prasad Eye Institute, which includes quaternary, tertiary hospitals, secondary hospitals, and primary eye care vision centers. He enables organizations to take the digital leap and harness the potential of data to derive insights for research. He's a TED Senior Fellow, AIYD Fellow, and a Chevening Fellow from the St. Cross College, University of Oxford. Interestingly, after developing a lot of solutions, technical solutions for eye care, he currently serves as chairperson for the Fernandes Innovation Forum to develop solutions for obstetric newborn care um, in that sector. So he he is truly a transdisciplinary person, both clinical work and innovations, as well as across the clinical disciplines. So welcome both of you, and absolutely kind of privileged to have you both here and to listen to you and your experiences across years and decades. I would request Shay to go first and share with us his experiences and evidence from implementing statewide health management information systems. Shay, over to you.
Thank you, Pavitra. Namaste, everybody, and congratulations to IIM Udaipur and BHS for organizing such insightful webinars on a very important topic of primary healthcare, and that's where we all meet. And over next 15 minutes, uh, we would share our experiences of how digital health technology in hands of frontline health workers, health managers can really improve health outcomes, provided there are certain prerequisites and certain critical operational requirements which are met. And on the request of Dr. Pavitra and Vedaji, I will focus on an evaluation part of a particular digital health solution which is very close to our heart. And the name of this digital health solution, the core is called MedPlat. And over last almost 12 years, this journey has been a fascinating journey of reaching the most underprivileged communities in need through state-of-art digital health solutions and improve health outcome. So this is a collaborative work. My organization, Seva Rural, our IT partner, Ayus of India Limited, and the state governments who have worked kind of come together and make this possible. So I want to go back to 2012, the early days of National Health Mission, where there were ashas in all the villages, and we knew what worked. We knew that the home-based interventions help to improve mortality rates. However, the challenge was, how can we improve the coverage and quality of the health services to be delivered by frontline health workers such as ashas? So it was an issue of an implementation science. How can proven home-based interventions, the coverage and quality of which can be improved? So Seva Rural has extensive experience in working in this domain of community health. But to answer this particular question in a larger scale, in the public health system, requires deeper understanding of the problem before we move on to the technology part. So many meetings such as these in the huts below the tree took place between us and many of the health workers and ashas, and we realized that the health workers had some legitimate barriers. One, sometimes the scheduling of these home-based newborn care visits are not very easy to remember. Two, some of the algorithms used for screening of high-risk conditions is slightly more complicated than maybe the health workers can understand. Third, suboptimal quality of training also made things difficult. So this, and fourth, the health workers, especially ashas, many times were not getting the performance-based incentives on time. So these were the some understanding that we received from the health workers. Now, if we go up to a level higher, when we go to the PHC level, the higher level, they told us that we don't get real-time information about certain complicated high-risk cases. Therefore, we cannot allocate our resources to take care of those high risk problems. At the higher level, they told us that we don't have timely, good quality data for supportive supervision. So this deeper understanding helped our multidisciplinary team to create a solution, a digital health solution, a mobile phone application, and a web-based application. We met our IT partners at the same time who had done earlier work in this domain, and we put our minds, how can we overcome these challenges? So we created a mobile phone application that gives scheduling to the health workers. It gave the checklist and the algorithms to screen the pregnant women and newborn babies and infants and come up with a probable diagnosis and the treatment plan. And there were also reports that were created for higher authorities so that timely, good quality information is available. An incentive module for ASHAs was created so that they get timely incentives. So these are some of the kind of a comprehensive list of technological solutions that our team developed after listening to the health workers. And this is a comprehensive list. I listed out some of them. But these were very early days, right? This was 2012 I'm talking about. These were the new days of smartphones. So in first phase, we wanted to see whether this mobile phone application is actually acceptable to health workers or not. Ashas who are semi-literate sometime, they are living in a village. Would they really use these smartphones? So we did a small study with 45 Ashas to understand whether this is acceptable. This was a mixed method study, and this was very interesting because we found very interesting insights. The metric used for acceptability and feasibility were this: proportion of working days when Asha logged into our mobile phone application. If they are logging into this mobile phone application every day, this is an indirect suggestion that this is acceptable to them. Second was proportion of due services that were marked completed by the Ashas through this mobile phone application, what we call task completion rate. So if the task completion rate is high, we would again, this is an indirect indicator that there is a good acceptability among health workers. And we found during that time that both of these numbers were more than 80%. And this was very heartening that this application, even in those early days, was acceptable to Ashas. But again, we spent a lot of time in the field using our ears and eyes. And we got a lot of ideas to make this application further simpler, effective, and easy to use. The Ashas told us that this is still a little complicated. Please make it more simple. And what we also found that there are certain enablers to improve acceptability, such as change management, timely resolution of technology solutions, and supportive supervision in form of hand-holding. So let's say somebody has a technology issue, we aim to resolve that within 24 hours. So these were some important enablers to make the technology acceptable among frontline health workers. These are extremely important as the technology piece. So now in 2015, we were ready to test this out in a randomized control, a cluster randomized control setting, where we wanted to answer this research question. Can a mobile phone application as a job aid in hands of Ashas improve coverage of the services to be delivered by Ashas? Right? Because this was the original problem statement that we identified. So coverage of services by Ashas were our outcome indicators. And our intervention was the digital health solutions as a job aid in hands of Ashas and the PHC staff. Number one. Number two, can digital solutions improve coverage of care among complicated maternal, newborn, and child health cases such as pneumonia, sepsis, low birth weight. And number three, is this cost effective? These were the three research questions. And we included 22 primary health centers in this study. These were spread across 6 tribal blocks of Bharuch and Narbada district of Gujarat with population of 5 lakh. And this was a cluster randomized trial. A PHC was one cluster. So there were 11 PHCs randomly allocated to intervention area, 11 to the control area. And everything was same except introduction of the digital health application in hands of the ASHAs and PHC team. There was a data collection at baseline and there was a birth and death surveillance that happened throughout. And this was a 3-year study. And at end of the 3 years, we looked at the results. But before we see the results, I want to make sure that certain roles of all the agencies who are involved in this trial was clear. So Seva Rural had certain roles. Argus of India Limited, our technology partner, had certain roles. And the government health system was certain roles. The government actually were the co-investigators, officers, and most of the work was done by the government public health workers. Seva Rural provided hand-holding support to the health workers, training, and identification of any technology issues. And we had a call center where the health workers can call in and report their problems. Change management was an important part of our role. Argusoft role was software development, customization, and timely resolution of problems. And the health department led the implementation. They were the primary and only service providers. We did not get into service provision. And our primary outcome here was the coverage of home-based newborn care. 2 home visits by ASHA within first week is very critical. It is very much linked to reduction in newborn mortality. So that was our primary outcome of interest. So that was our one primary outcome indicator. So as you can see, the coverage of at least 2 home visits by ASHA improved significantly, almost by 40%. The second part was a composite index, composite coverage index, where the index was made of multiple services throughout pregnancy, delivery, newborn, and infant care that we created. And that is an indirect indicator of the coverage. So that also improved significantly. And as we can see, it was significantly improved. More importantly, the infant mortality rate was 16% lower in the intervention arm compared to the control arm when we did the per protocol analysis. So this is huge, right? 16% infant mortality rate just within a span of 2 years in a randomized control trial. We were very encouraged by that. And a cost-effective analysis done also showed that this intervention was highly cost-effective. And there were multiple publications that has come out of this work. So what lessons were learned? Number one, digital health solution is surely effective for improving coverage, provided adherence to and the fidelity to the intervention is ensured. Fidelity means that people, the health workers, use the applications on regular basis as we expect them to use. And to ensure adherence, the critical operation requirement is timely resolution of technology problems, good supportive supervision, health system preparedness with focus on internet connectivity and change management. The fourth important point that we found is aligning project objectives with personal motivations of health workers. So just reduction in infant mortality or maternal mortality is sometimes not enough. We have to bring in providers' perspective, whether they are getting incentives on time, whether they are getting acknowledgement of on regular basis through technology and non-tactical intervention was very important. And the last one was ability to work in a multidisciplinary team, which sometimes is difficult for public health people like us, but this is something which is very much required. So we received support from multiple generous donors, and at the end of the study, we had a software product, the toolkit to take it to the next level, and then this is the last slide. That this study, after this study, the government of Gujarat was very encouraged, and they took up this entire intervention with some important modification in the entire state of Gujarat, and subsequently in the state of Uttar Pradesh and Union Territory of Dadra Nagar Haveli Daman, as well as Zambia and Cambodia. This intervention has gone. The scope has improved through from RMNCH to non-communicable disease, communicable disease, and many other programs. And this particular platform is now integrated with the national portals and is compliant with the Ayushman Bharat Digital Health Mission. It's a digital public health good. It is meant for social good. And but what is very close to heart of our all the agencies who are involved is to continue to remain rooted in the grassroots, remain humble, remain authentic, and that has been a very meaningful journey. Thank you for giving Seva Rural and everybody who's involved in this agency the opportunity to share our learnings. Thank you.
Yeah, this was excellent, Shrey. Thanks for sharing this very impressive journey, but also in a very succinct and in a short manner. Also highlighting that what are the enablers for this kind of a technological intervention to actually take root. It's not sufficient to have a great technology, but poor systems or demotivate people who use it. So I think this combination of using a systems approach and then integrating technology was has been probably key to and maybe later we'll get to ask you a few more questions about understanding it a bit more and also its implications. But thanks so much for sharing this and over a short period of time. I'll request Dr. Anthony Vipindas to share his experiences of using technology in healthcare um, at various levels, but uh, focusing down on its implications for primary healthcare. So over to you, Dr. Das.
Thank you, Dr. Mohan. At the outset, I'd like to thank Professor Veda and Dr. Mohan for having me today at the webinar. And what I will aim to do for the next 15 minutes is to kind of share some experiences over the past decade. So we all know about 70% of our country is in the rural geography, and it is definitely our responsibility that we ensure that we use technology to be able to reach the ones who do not have access to healthcare. So in my talk today, I'm going to be talking about the work that I did in my previous organization at the L.V. Prasad Eye Institute for Ophthalmology, and then an example for education in maternal health and also large-scale public health screening for early detection of cancer and non-communicable diseases. So the first example, I'll start. The L.V. Prasad Eye Institute is a 308 center institute, and it has got the eye health pyramid, which basically has a lot of vision centers and vision guardians who are out there in the rural villages and who basically conduct vision screening and also are the outposts where people present to get screened for ocular disorders. So what we did was across the quaternary center, the tertiary center, the secondary center, and of course the vision center, which is manned by a vision technician, we actually digitized the entire network through building the iSmart EMR system. We also did publish our experience from mining this big data across the entire pyramid. And it also is a HBR case study about the process that we've gone through to build the entire system and also deploy it, including a review in Nature. Then I'm going to be showing you specific examples of our experience in the rural network when it comes to specifically screening people with avoidable causes of blindness. We built an app which is called the iSmart EMR app that currently is deployed all across the vision centers. And we also wrote about our experience of building the app and deploying it in a very resource constrained setting of not having enough internet connectivity. So the app being used online, and how do we ensure that the data flows in to the central data lake as well. And we also basically looked at the role of the use of teleophthalmology as well from these specific vision centers, because the eye is an external organ, and you are actually able to image the eye either through a simple external clinical photograph or a slit lamp. And we also kind of developed the teleophthalmology through the app, where we could actually take pictures, and we also identified cancers as well out there in the rural network that were referred for appropriate care. We also developed guidelines about who should be referred, who should not be referred. We also published our experience about the implementation of these guidelines as well, where we had a different color triaging of patients in red, yellow, and green, depending on the severity of the ocular conditions that were diagnosed in our rural network. So here you can actually see examples of how the vision technicians, they're out there in the village, and they are able to actually take pictures and transmit this to the central teleophthalmology command centers in the tertiary centers, from where the advice from the doctor would actually be sent straight back to the app and handed over to the patient as well. And what also we did was we also used a bit of innovation of 3D printing on how we would basically attach the tablets to the slit lamps. And we also kind of shared our experience about the use of the iSmart Cyclops as well. But apart from that, what we also did is to basically, develop a 101 kind of a thing of how do you start setting up these centers equipped with technology out there at scale. So, setting up, technology for teleconsultation. And as I mentioned about the different guidelines that we developed and also published our experience of the usage of these services in a better manner after we trained them with regards to the triaging that you see on the screen, a bit of all the processes, and you can actually see the command center that is used to basically, answer the queries that are coming in from the village centers. But also what it enabled us is during the time of COVID, because the whole system was digitized, we also were able to understand the operational challenges, even in the primary rural vision centers. And actually, we published quite extensively about how our patients, because of the migration, actually started accessing the vision centers once the unlocks started to happen. So essentially, we saw a lot of patients access the primary rural network when restrictions started to be lifted up. And then we published also about the reduction or the increase in the patient pool across the pyramid. But not just that, the usage of digital systems also enables us to also have kind of a mapping at a national scale as well. So this is the country of Liberia, where LV Prasad also has a presence, where for the very first time after we deployed the EMR system, we were able to also map different regions of the country and the kinds of ocular conditions that people were coming to us in Monrovia from various parts of the country as well. The example of for maternal health, I'd like to highlight the Promise app from the Fernandez Foundation, which is a real-time digital monitoring tool to ensure quality midwifery services that was scaled across 4 states of India, and currently now looking at another upgrade in terms of developing protocols, educational protocols for sign-offs. So the app was piloted in 2020 across 4 to 5 states. And, there are about 77 midwifery educators and about 433 midwifery learners. So essentially, the app was used in a very effective way to monitor and track the progress of individual trainees, which were the midwives, and how It was built on Java with all the necessary data security and protection. There's an end-to-end data capture analysis, but more importantly, for capacity building and assessments, it continues to serve as a very, very valuable tool for us, and it's also continuous real-time feedback. And on top of this, as we are planning to continue to scale through our outreach programs for midwifery training, we are also looking at using AI to basically look at standard, feedback to individual trainees as per their journey in being trained by us. So essentially, there's a live dashboard, clinical competency assessment, resource material, and key information. And the whole dashboard and login data of all of them from across different states is basically tracked in real time, including their attendance, their internship, their daily log as well. There's almost been a 3.7 million interactions that have happened on the app specifically, and we are looking at now mining this in a way for us to be able to understand different patterns so that they can be developed into best practice methods as we continue to scale the app in the other states. So just to give you the granularity of the kind of information that we are able to track in terms of the interactions of midwives, both in different stages of labor and also the profile of the mother as well. So here you see an example of how you continue to use technology to be able to use it for capacity building and also training in maternal health. The third example I would like to share with you all is the Grace Cancer Foundation, which is a not-for-profit, and the vision is to alleviate cancer burden in the society, but GCF does it through 4 arms, which is education awareness, early detection, treatment and rehabilitation, and cutting-edge research. But for this talk, I'm going to be focusing on the early detection, which encompasses the biggest vertical of GCF, where there are mobile cancer screening buses that actually go out into the remotest areas of India, and they screen people for non-communicable diseases, and they also perform mammography, chest X-ray, and also Pap smear for early detection of breast, lung, and cervical cancer. And all of this data actually flows in through a system called as NeoPact, which is actually utilized by the team. And of course, there are challenges when there's no internet connectivity. So we continue to, use paper and then, feed it back. But then, of course, where there's internet connectivity, everything goes into the NeoPact app. And as you can see, people with absolutely no access to good care, diagnostics and advanced screening facilities are brought more closer to the doorstep of the rural population. And this was the screening of the tribal villages that was done in collaboration with the SLS Trust of our Honorable President, Srimati Draupadi Murmu. And you can see that technology is taken more closer, but more importantly, we are able to capture a population profile or a geographic profile of the current burden of disease for being able to kind of deliver the right treatment or the advice. And of course, after that, all of the abnormalities, the advice, the kind of diagnostics, and all of these things are basically visualized. And this was a recent thing where all the, in collaboration with the Society for Cyberabad Security Council in Hyderabad, screening is basically done in the most remotest of the areas. And the technology that is used is now visualized in terms of the impact that it is creating. And some of the other examples of geographic mapping of patients or the individuals that are screened, different kinds of diagnostics that are basically performed as well. So what I want to kind of summarize now for the later half of the talk, I've shown you 3 examples, but all of these have a common basis and a framework on how you look at how digital health empowers us to be able to deliver both care and also scale the care that is being given to our patients. So any data point, there's volume, velocity, veracity, and variety, but we have to derive value from the data that we are basically gathering. And what data allows you to do is to either find patterns in it. It helps you find trends for you to be able to pivot, or with that derivative, you're able to take decisions. And then you also are able to find relationships, whether it is between social determinants of health, whether it is clinical presentation, whether it is treatment patterns or outcomes. So we have to be mindful that what we collect and what we are able to visualize has a lot more in it that needs to be discovered. There are various possibilities that are available to us if we do it right. So uh, even in primary healthcare, there's clinical information that is being captured. You saw the example of how eye images and media was effectively used to be able to triage patients. There's also a great opportunity for us to look at the health economic side of it in terms of the cost effectiveness and the cost utility of the programs and the protocols that we basically are able to roll out in the rural healthcare setting. And also, more importantly, operational turnaround times, efficiencies, delays, reporting, and all of this data is kind of a gold mine for us to further make our delivery of care more efficient. Of course, there are a few challenges in the primary healthcare setting. Per se data, per se, as Professor Veda had mentioned, data is everywhere, but do we have the right kind of insights? Well, we also have to be mindful of the data integrity and the data quality that is being inputted, both in terms of the digital tools that we build. Funding is an important aspect. Actually, there has to be a mandate from the leaders, whether it is at the national level, at the state level, at the local level, or even at the institutional level. There has to be a mandate from the leaders to be able to explore and use these new tools, and ensure that there is adequate funding for us to not just develop, but also sustain the platforms. Rural connectivity has gotten a lot more better. And as Dr. Shea was talking, going from a 512, kbps line to a 1 TB line has been a lovely journey for us, as we have used the benefits of, how connectivity and internet also has enabled us to be able to build these tools, and we evolved over the past, 10 to 14 years. And standardization also is very important in terms of how we diagnose or how we capture the data, because there has to be some sort of a standard protocol for us to be able to compare it with other published research as well. So I'd encourage you to read one of the perspective article I'd put in a few years ago about the people to policy and the promise and challenge of big data for India, where we talk about how important it is for us to have some of these foundational principles, because how digital systems are built, it differs on who's asking the data. And it could be different for a doctor, different for a patient, different for a policy member, different for the government, or different for an insurance agency. And it's important for us to be mindful of that. And a lot has been also discussed about the ownership, privacy, and the value of healthcare data. And this was an article put in by, along with Professor Madhu from ISB in Hyderabad, where we discuss a bit of the perspectives and future direction also of how we should be mindful about how we use de-identified data according to the regulation of the region for us to be able to derive the insights that we intend to get. So as a final slide, I'd like to conclude that there are 2 C's, 2 A's, and 2 P's to do, right? So in primary healthcare across this, it's a great opportunity for us, number one, to collect. Number two is to collate. When apart from just collecting, you should be able to collate standard data across the region. We have to analyze it, and we have to act on the insight. That's the most important aspect. But not just that, we need to share our experience. We need to publish whenever possible and wherever possible. And that will, of course, aid in policymakers to be able to take the right kind of decisions. And more importantly, when we share our experiences, is how we learn, across the board. So thank you so much for your time. And once again, thank you for the kind invitation, and happy to take questions. Thank you.
Thank you, Dr. Das, and thank you, Dr. Desai. So this was very insightful from both the MET platform that Dr. Shrey was talking about, as well as iSmart, which has been a key enabler in collecting all those data for the improvement of patients, as well as using such a solution across various domains like maternal health or cancer care. Seems to be a lot of things that where the technology is actually helping. I have a few questions just to get your ideas and thinking a bit more about how to think of the technology that you have already described to take it further and at scale, right? So my first question is to Dr. Shrey Desai. So, one of the key things you have spoken about is about the need for the change management, right? How do you resolve some of these technology issues, providing supportive supervisions and all that in changing the attitude of people, in motivating them to actually make use of the technology, right? Now, when you're doing it at a pilot scale or at a scale where there is close supervision to kind of get it done, it definitely, it has proven itself. Now, when you have to take it at scale, right? When you have to move this beyond certain segments or only for certain services, and when you have to take it outside the area or the context where you are actually designed that solution, what are the kind of challenges you think that may come up? And you spoke about how it has now been rolled out across Gujarat. So was there a different kind of challenge? How was those met? And more insights on that will be helpful.
Yeah, that's a great question, Veda. And if things definitely gets, I would say, more interesting when you take it to the scale. Of course, challenging, but I would put it as a more interesting. And right, because number one, we are interested in impact. We are also have a humane approach and a sincere and an authentic approach that we want to take. We are here for impact. We are not just here to show numbers, is where we are coming from. And therefore, it makes it very interesting. The challenges that comes along is in the numbers. Change management of 45 ashas is relatively easy, but change management of now 2.5 lakh users who are using this system as of now on daily basis is different. So that's one. And number two, also change management at different levels, not just frontline health workers, but also at PHC or a district or a state level, or even national level. I think that is also something that we have to keep in mind. Now, some of the things that has helped us to overcome this challenge to a good extent, please allow me to share. Number one is it's a mix of, so number one is the frontline health workers who is living 500 kilometers from where I am living. Okay, that person needs to get formal instructions from the higher up authorities that you got to start using this particular digital platform, this or that or whatever. A formal instruction is an important part of change management. And then so that's number one. I think that is the basics of that. I think just hoping that the goodwill and the great application will make them adopt it is no go. I think first thing is some kind of formal instructions from above. But second thing is that it is important to continue on the positive side of positive communication. I'll give you an example. In this platform that I talked about, we have a feature in a mobile phone application where you can broadcast messages, right? And now it is available in many applications. In those days, it was very early on. So what we do is that we, if there is a positive case study, we would broadcast that in this and this district, this and this village, an ASHA worker or ANM Didi did something very great. It saved a life. Congratulations, right? So when that kind of acknowledgement also helps with this kind of change management. Number three is very effort intensive but very important, is two-way communication at multiple levels, right? So like there are three agencies involved and we keep having open communication channels almost on daily basis. What I mean to say is that, let's say a health worker in a particular district is facing some technology problem, they have a opportunity or a communication channel to report that problem, which reach which kind of gets solved in 24 to 48 hours. And if it is something of a very, integrate technology matter, then of course it reaches ArguSoft and they solve at the code level, at the software level. But for that, there are multiple WhatsApp groups, of ASHAs, ANMs, where we are also part of it, and we continue to listen to them. And this is also another important part of change management. The fourth and last part is remaining authentic. Continue to spend time in field, in the community setting, in the facility setting, and figure out what's going on, what people are facing, what challenges are facing, and try to make a meaningful product which is useful to them, which solves their problem, not my problem, not just programmer problem, but their problem, also goes a long way, because people then realize कि हाँ ये लोग सुनते हैं मेरी, they are listening to me, they understand my problem. So that kind of relationship is built not in one day or 1 year, it takes few years, but fortunately to a large extent that has happened. But change management is a very important and interesting thing. It requires a lot of patience, especially of the innovators, because sometimes we are in hurry to get things out, in hurry, but sometimes we have to take time, spend a lot of time. We have to use our ears and eyes more, and sustain that trust of at every level is a key to change management. Sometimes the last part, one small example is that we also created a song, actually, a Gujarati Sanedo. Sanedo is a folk Gujarati song, okay, Sanedo, and about this application, that how this application is going to help you.
Mm.
And so that's how kind of it's work when kind of it helps with the change management. So there are quite a few things that technology can offer to make it possible.
Excellent. Yeah. Thank you so much. So that talks a lot about, the human element of technology adoption, where, you're consciously working on recognition, you're working on two-way communication, trust building, even to get the technology adopted. So which is a key element in making sure this gets used. So changing a track a bit more, I wanted to ask Dr. Das on about the backend part of it, right? So about the integration part of it. So we were talking about many of these applications. We are collecting data, but at the end of the day, to be actually to actually make use of some of these things in decision making, unless it is available to the doctor or to the health worker at the time that they need, in an app where they are using on a day-to-day basis, it is not going to be of much use. So I wanted to understand your experience, because you are part of the design team, or you are actually driving the design of the entire system. The importance of integration of these technology solutions in day-to-day use, right? And how that enables decision making. What has been your experience there?
Thank you, Professor Veda. And I want to kind of also clear, there's a myth that people can't use technology as you go down towards the rural areas. You will be pleasantly surprised how people love to utilize these tools and to be able to kind of use it to help them in their daily processes, right? So when people talk about input of information, where I'm coming from is people say that, oh, it delays you. Technology, will make you, force you to do it in a particular protocol. It will take a lot of time. We don't know if the literacy of the individual is enough for them to be able to use these tools. Well, we've proven them all wrong, because people at that geographic level are able to use these tools. When it comes to data, Professor Veda, the way I want people to look at it basically is, have a goal in terms of what you intend to measure or intend to, have an impact on, right? I mean, there has to be a few number of metrics or KPIs that you define, right? And some of them might be new as you kind of build and deploy the system. It's not like you can have the whole thing off. The most important aspect is, as a technologist, as how we, Dr. Shrey and us, who basically design the forms, look at the input of information, it has to be a balance. It has to be a balance. The standardization of what kind of input also is put. There are guidelines, there are EMR guidelines for a country that have been launched in 2016. There's a way for us to be able to see how do you use for a geographic input for where the patient is coming, social determinants. There are some tools that you can use, socioeconomic status that are there. There are standard diagnosis tools that are both the ICD and also SNOMED. So we will have to actually strike a balance in terms of both the load of the application, the simplicity of its usage, and also the ease of us to be able to input the data into a database to create a data lake. So essentially, when you have a lot of de-identified data, there's no patient identifiable information apart from a unique ID. But then you start from age and gender to at least have this distribution of the kind of data that is coming in from the field to you. So these are some of the things that you have to keep into consideration. Practical things, not the textbook things of how you go build a code, but you have to be mindful of this. And my simple suggestion is fail fast and learn. There is no 100% proven method that says after I get to know everything is when I will build, after I get to know everything is when I will deploy. It doesn't work that way. You will have to do pilots, just as Dr. Shreya has beautifully showcased. There are small pilots that you will have to do to quickly learn. You will have to modify, and then you will have to use that information to scale.
Sure. No, that's definitely useful. But a follow-up question to you is also maybe also to Shrey is, so we have these solutions which are coming up, a lot of such solutions in India. But what I'm worried is how are we going to integrate it across providers, right? So for example, Elvi Prasad has a solution. And as a patient, I come into a provider, I have some medical record with LV Prasad, or I go to a different public provider, and there is something that is getting entered through my ABA card or somewhere, right? Now, I know there is this plan of integrating all of these in the back end, so that as a patient, as a individual, I have all my health records in one place. I wanted to kind of understand how far are we in getting this integration to work in the back end as a country?
Yeah, Professor Veda, thank you. It's always been the most important question that I've been dealing with it for over a decade and a half. And let me tell you this: it's completely dependent on the rate at which we as a nation adopt electronic medical records. And let's be very, very open to the fact to understand that the amount of EMR adoption is not that great in the country. I'm not talking about healthcare information systems. I'm talking about actual clinical data with a diagnosis, with an outcome, with a prescription is most important for us to encourage our clinicians and institutions to adopt. That's number one. With regards to this integration that you're talking about, because the topic was on primary healthcare, I didn't bring this, but there's a very exciting initiative that I'm part of with the National Cancer Grid that is led from the Tata Memorial Hospital in Bombay. And for the past 2.5 years, along with the Koita Center for Digital Oncology, we've been working with that group to kind of standardize the EMR requirements for oncology-specific EMRs in the country. And we've done that with a very extensive exercise. And apart from that, what we've also done is we've standardized a data dictionary on what kind of variables are we bringing in from these EMRs. The third step is what you've basically asked right now, is from the same data dictionary, there's been another national subcommittee that has looked at interoperability of medical records, right? So what I'm trying to get at here is that as organizations, as consortiums, or as institutions, we have to take the leap, show the proof of concept. It's great to have a white paper. It's great to have a policy paper to say it's good to do this, but we need multiple proofs of concepts across the country to learn, and then together build on that as what needs and what is relevant for the country, right? But I'm very excited to share with you. You'll see as we evolve on that. But we have been able to reach a stage where the interoperability of the case sheets of cancer patients is standardized for us to be able to move it between the EMRs. So
excellent. That is very promising, Dr. Das. So that I hope we are able to do that across all the other kind of medical records as well, and connecting the primary to tertiary providers as well. So again, on that question, on the same note, Dr. Desai, I had a question for you on because of your work in the rural area. So one of the things that you were mentioning, or what I read about the platform is, even to get on the platform, a mother or a pregnant woman needs to have like an Aadhaar card or some ID and so forth. Of course, we know that there can be instances where someone doesn't have those basic things also, right, in some of these tribal and rural areas. Are we creating a digital divide, or a technology is, how is technology coming in resolving this issue? Or what, is technology creating a divide, or is it trying to resolve that? Have you seen instances where we have been able to achieve more equity in primary healthcare provision because of technology? Can you give us some insights based on your experience?
Right. So, Veda, please allow me to actually touch upon the integration part that you asked earlier, and
Sure,
then
sure.
come to the digital divide.
Yeah.
And I agree with what Dr. Das was mentioning. And so integration, that word is complicated. So we have to dissect that word and what we mean by integration, first of all. Okay. Does the integration mean that a patient has a personal health record of all the kind of providers that they saw, and they have records of all the different places in one place, a digital record? Is that what we mean by integration? That's the one part. And the second commonly used meaning of integration is that integration of, let's say, one platform to a national portal, let's say, for an example, national RCH portal or national NCD portal. That's a different part. And there are some other permutations and combinations. On the first part, for somebody, a patient, Shrey Desai, going to, let's say, Seva Rural Hospital, and then LV Prasad, and then, let's say, Apollo, and then BHS, and having my record in one place, I think Ayushman Bharat Digital Health Mission is trying to do that in a very, I would say, courageous manner. I really appreciate the concept and the approach and the speed at that the whole mission is going. And there are a lot of challenges there in many ways, but over the next few years, if the Ayushman Bharat Digital Health Mission really achieves the mission and the vision of why it was created, then the first part will be largely solved, that I will have an integrated personal health record. The second part about integration, about, let's say, one platform pushing data to a national portal, I think it is between, it depends on multiple things, but for statewide implementations, state specific platforms, to integrate with a national platform is something which is very important, that has to happen. Otherwise, people will end up using two different systems and workload will increase. Fortunately, at least in the MedPlat situation, there have been, integrations done with the national portals, and that has been one important positive aspects, and not to worsen the workload of the health workers. So that was on the integration piece. Digital divide is a topic close to our hearts. Why we exist and why we are into all this. We want to reach the most marginalized populations and be helpful to them. And there is is digital systems worsening that or improving that? is the question, right? And that question is very valid because let's say if you are in an area where there is no internet connectivity, would that Asha and that whole community will be devoid of digital health solutions, right? So that is how kind of that is one of example. So I think the key here is in the intent and the design. Okay, I think there is no one answer. I think the answer is it depends. Whether technology increases digital divide, the simple answer is it depends. It depends because if the designers of the platform and the implementation of the platform has equity in their mind from day one, then they would approach the technology in a way that it actually helps to reduce inequities. Okay, so for an example, I mean, many platforms, including ours, they can be used in an offline mode as well. Okay, so without internet, they can use it. Now, so that is one example. Second example is that we work on the problems which especially affect the marginalized population more than somebody who is well off, and apply technology on problems who are affecting those. For an example, let's say sickle cell disease. Okay, I'm just giving an example. So it depends upon how we approach, and if that intent is there, that approach is there from day one, I believe that actually digital technologies can reduce inequities. But the caution here is that if that is not there, then there is a risk that digital divide and inequities may increase over the period of time if that thought process is not there from the design phase. Yeah.
Thank you. No, yeah, Dr. Das, I don't know whether
Yeah, I
you
can
wanted
just
to come.
very quickly add to Dr. Shrey's thought process. I'm absolutely aligned to what he mentioned. The way I look at it is the digital divide, we have to understand the perspective is whether you put technology in the hands of the providers or in the hands of patients. If you put it at the hands of patients, yes, the divide will always exist. It will always exist. We have to empower the providers. As innovators, we have to think. It always used to be, how do we build for the most lowest resource constraint setting? And let me tell you one thing, before we even got these 3G SIM cards or 4G SIM cards, we would pay 10 rupees to the local nearest internet shop to sync the data of the tablet, right? I mean, our goal was, hey, how do we ensure that there is information passed to us so that we identify the patients at risk? Even if you look at the Grace Cancer Foundation, bringing the technology more closer to the doorstep, whether it be diagnostics or it is the technology of using Neopac, you're bringing it. So you're bridging that divide. You're decreasing that inefficiency of not being able to reach the masses. So I think it will be in phases. We empower the providers, then we look at the patients also responding. I see some questions about patients taking care of their data, them being more mindful about their behavioral aspect of how they access healthcare. So it's going to be a phase-wise evolution, I feel, Prasaveda. Yeah.
Thank you. And I'll request Dr. Pavitra to come on, please.
Yeah, thank you. I'll just kind of try to put together some of the questions that have been put in the chat box and maybe sometimes rephrase it and ask the specific panelists to respond to. So, yeah, I think taking from where Veda was asking the last set of questions, there are a couple of questions about ethical challenges, right? I mean, some of the ethical challenges, for example, about uh, discrimination based on access to technology or denial of services, right? I mean, because you don't have a question that actually Veda did ask, and I think Shrey to some extent answered, but also related to privacy. So I think on these two aspects, I would say, how do you ensure the privacy of the data and it is not used, indiscriminately, etc. And the other is the denial of services. So Shrey, maybe if you could kind of, based on your experiences, quickly share either in instances or in how you dealt with it, or yeah,
Yeah.
how would you like to respond to this question
Yes,
about denial, which we do see instances of that if you, because of the digital systems, a lot of effort goes in ensuring that all the data is, and if it is not available, then there are instances of denial of services as well. The other is of privacy. And how do you deal with it?
Right. So ethical aspects and privacy, I'll tell you in the early days, in our initial pilot, one of the health workers' husband threw her smartphone in the chula, in the stove, because he started suspecting that his wife is having an affair. Okay, I mean she's on the phone now too much. She never had a phone, now she has a phone and she's doing her things in the phone, punching numbers and what's going on. And that really kind of alarmed us that we are putting our health workers, are we putting our health workers at risk? And what can we do? So these are the kind of the situations that kind of maybe even arise nowadays that we have to be very sensitive about and find context specific solutions about involving, kind of larger stakeholders. So, for an example, we organized a Pati Sammelan about we got all the Patis in one place and kind of, inform them about what we are doing. So this is just one symbolic example I'm saying, but we have to be kind of, be careful about those things. About privacy of data, what I feel, Pavitra, is that at least in our experience, let's say for an example, our data, the data of the governments, they are staying in the data center of the government. And the data center of the government, they are following certain policies and practices and standards, which are largely keeping the data, well safeguarded. Um, that being said, there are, as I said, there are 2 lakh people who are using this system. Can there be a data breach? Could be. We have not come across any situations, but those kind of risks do remain. And I say this is a journey. I don't see even denial of care for, let's say, our kind of systems where you don't need any Aadhaar card or any PAN card or even Aadhaar card to get enrolled. You get enrolled irrespective of you have any card or not. So that is not the situation. But I do know that there are certain platforms out there which kind of are more, restrictive and and that put people on at risk. So I it's a journey. I think we as a country also we are learning how to go about kind of approaching these very difficult issues, which sometimes we don't always have immediate answers to. But people are putting their mind about how to go about doing all overcoming many of these challenges.
Thank you. Thanks, Shrey. That was well said. Uh, Doctors, there are a couple of questions that I think you would be best suited to respond to this time. One is around the NCDs and other diseases. You talked about cancer and other stuff, which requires more continuity of care, which requires adherence to treatment and follow-up care and continuity of care. So, how does how can, in your experience, what has been the experience of using technology for ensuring continuity of care, especially for non-communicable diseases, etc.? That is one question. I'll just ask the second question simultaneously, though it's different, which is that you've used technology for various purposes, right? For training, you talked about the midwifery model where you used it for training. Then there is use for big data analysis, generating insights, and using it for planning, etc., and for informing policy, education, etc. So, which of these do you think has the greatest traction with providers in general? So, any thoughts on that? So
No,
both these
great. Thank you, sir.
questions, yeah.
Yes, yes. Thank you. So I'll answer the first continuity of care from the eye care perspective, because the Grace Cancer Foundation does screening, which is a one time. It's public screening. So there are patients who get referred to different hospitals. So essentially, that platform is used to look at a population profile in the region that we are at. But yes, technology wise, what the patient would basically have at a vision center in the LVPI health pyramid would be accessible all the way to the quaternary care, and then again back down the pyramid, right? Because as I mentioned, it was all the same structural framework behind and how the data was being captured. And this is also the beauty of digital health technologies. It allows you to see some sort of trends, whether patients are worsening, whether patients are benefiting. Even with the initiative of the NCG, Dr. Mohan, the whole goal basically is to be able to have that temporal access of all the aspects that the patient has undergone in the complex journey of cancer care, right? And how do we ensure that all of that is simplified to an extent where it is summarized, right, for another healthcare provider to be able to input that information both on the technical aspect and maybe on the clinical care aspect, right? So I think that is a very definitive benefit on why we should be able to use these technologies. And even in the public health setting, you can have review visits of patients who keep coming back, right? So the review visit also kind of adds on to from the primary visit for following up patients. Coming to the second point of traction of why people will use these things. Number one, I feel, and also adding to what Dr. Shrey has mentioned, if you look at the digital landscape of the country, you would also notice that right now, as institutions are becoming more digital and more technologically advanced, you also see the attacks that are happening. You know, one of our large national institution got attacked and was down, right? So what I'm trying to get at basically is that uh, we have to be mindful about uh, the other aspects of technology advancements that are happening in other fields, and we have to get onto that bandwagon, right? We cannot just stay on paper expecting that this is going to be something that. So I think the generation that is going to now train as healthcare providers is going to be more digitally conducive, or maybe more digitally tuned, if I may say. And I think there lies an opportunity for us to be able to encourage the use of tools while we take care of the security issues, we take care about all the other threats and risks that we will basically have. And of course, I must say that there are enough threats and risks that are happening in the other sectors that we are all mindful of, right? So healthcare is not something new, right? But of course, it's we have to be mindful on the consequences, and other aspects before we go at scale. So I'll end here. I mean, there's no like a specific answer, but I think overall I see that as a nation we should be pushing to adopt and adapt.
Thank you. And I'll just add thoughtfully, as you and Shay said, I'm just kind of paraphrasing that. Adopt and adapt, and thoughtfully and with patience. I'll come back to it. But thank you for that response. Just one quick question. Somebody asked about about specifically about the ophthalmology, but it could be related to other kind of wherever you are using telemedicine kind of approaches. That how effective they are, and what as compared to the standard provider directly kind of consulting.
No, absolutely. And the reason why telemedicine came to the fore was because of COVID. When the entire planet shut down, telemedicine came to the forefront, where we were still able to at least talk to our patients. And because the eye is an external organ, we were able to take pictures and at least kind of get a sense of what was happening, right? I'm not saying that it was a complete thorough clinical examination. There are restrictions in how you can use telemedicine for certain disciplines in medicine. It's a given. But in certain things like psychiatry, if you notice, right, there was this element of privacy. And there was a huge kind of a leap for people to anonymously or even, behind the screen talk as well, right? So there is a definitive role of telemedicine. But again, as I said, even what we can prescribe on telemedicine as prescriptions has been defined by the government. There's a very, very specific guidelines for telemedicine in India. And I think we should understand our limitations in its use. But yes, there is a great opportunity because, as I mentioned, also we were able to pick up potential eye cancers out there in the rural healthcare setting, which probably they wouldn't have had a chance, right? But every life saved is every life saved, right? Or every eye saved is, or vision protected. You feel happy that you've done. So it's as Dr. Shay said, it's not about the numbers. Our number is one. Even one is done. It is an impact that we are, and that one multiplies and scales up. Yeah.
Thank you. I think that's well said, and that kind of takes us to the end of the webinar. It's very difficult to sum up something like this. I'll just try to probably put a few thoughts together and then request Veda to conclude and thank the. So I'll just end in no particular order. I'll just share some of the points that I at least kind of captured. And I think it's a generational thing. And of my generation, I've been a kind of a tech skeptic, but changing, trying to adopt and adapt as time goes, but also to bring in some of the elements that I think both of you talked about. The one thing about, so I think in general, what we listened and what probably is the way ahead is that technology is a huge enabler. It can be a huge enabler in every sense. However, there are a few kind of uh, elements that are important. I think Shay talked about patience, right? That it is thoughtful, it is patient. It kind of took him several years to build something that could then be used. The second was that from Shay's presentation was that how do you, if it is designed in a manner which is for impact and for equity, right? I mean, so it is equity by design, so it has to be integrated in the design of what you do, not a afterthought that, oh, now it is kind of not reaching people, and or so how do you design for equity and for reach? One thing I took from Dr. Das's presentation was that there are several steps to effectively using data, from generation to collation to analysis to feedback to making sense to policy. And if we don't design for it or don't use it for all these steps, it is probably not really helpful. Uh, in the design itself, I think you mentioned there's about the ease of use. So I think those are the design principles. That how do you design for ease of use? How do you design for equity? How do you design for privacy, etc. Um, One thing that and I think the change management that Shay you talked about, that how do you not only look at technology in isolation, that you introduce it in a system which is not ready to accept technology or to make use of it adequately, and how do you work on some of the other peripherals. And it is even more important when you are working in a system which is not in your hands entirely to and therefore continuously working with the systems to ensure some of the enablers which are extremely important things, even like supportive supervision or conducting pati's sammelan, you know so things like that are not, a regular technologist would never think about it, right? I mean, they'll say that it's for you to now use it or throw it or whichever, but if you're really looking for an impact, and that is where I think this kind of an integration of one of the things I always felt, there is a gap between people who use it and people who develop technology, and when they come together and ideally in the same person or at least in the teams, then it becomes more effective. And finally, I think something we all believe, and that is where primary healthcare's core principle is it being human centric, right? And that's where I think your last comment, Dr. Das, and Shay's earlier comments, that people are at the center. And even one number is, if you are able to detect someone with, and therefore from design to execution to evaluation, if we keep people at the center, then the technology with the human face is probably what we need as the way ahead. And that would kind of help address challenges that come ahead of ethics, of discrimination, etc., provided people are at the center. So with these words, at least I will kind of conclude from my side. These are the messages that I have taken home, but I'm sure there will be many more as we listen back to it and continue to kind of work together on this journey of enabling healthcare to people. Veda, over to you.
Thank you so much, Pavitra. So from design to integration to human element, and finally talking about the enablers of technology today in today's forum had been really useful for all of us. I take this moment to thank both Dr. Das as well as Dr. Desai for joining us today for this very insightful webinar. I thank all those who have joined us today. Thank you all. Stay tuned for the next episode sometime very soon on technology again, the second episode on technology in primary healthcare. Thank you, everyone. Have a great evening. Bye-bye.
Thank you. Thank you, Dr. Mohan.
Bye.
Professor Veda, thank you.
Thank you.